Hi, this is Willow Health Media. I am Sarah Okoro. We're going to be discussing some quick questions, frequently asked questions about the Social Health Authority. I'm here with the chairman of SHA. This is Dr. Abdi Mohamed.
Thank you.
I have a few questions that I don't say common wananchi, but that Kenyans would normally ask about SHA. And one of them is, we'll start simple, yeah? So should I carry my NHIF card when I'm going to the hospital?
You don't need a card. You will use your national ID. That's what you will register with, and that's what you will use.
Will I get all the services at my local facility?
You have an option to go to any of the following providers: public, private, mission. So anywhere that you will get services from is where you have the freedom to go to.
Okay. Is my nearest hospital well equipped to provide all the services?
That's why you have given you the freedom to go to. If a facility is not equipped enough to provide services to you, you are allowed to go to the next facility that has the facilities and is able to provide the services. We are not limiting you to one facility.
Okay. Can I lie about my income when I'm registering for SHA?
You can't lie because you will be asked questions, and that's now what determines what is your premium. So you will
How
be
will
able
you
to
know?
we will not know, but you will be able to answer the questions, and it will be able to triangulate what exactly is your premium based on the answers that you have given.
Okay.
And why would you lie?
You never know. So how will I know how much hospitals in my primary care network are going to charge for the services I'm seeking?
So for primary care network, you don't need to know what they are charging because there will be no co-chargement in your primary care network. All you need is to register and go to the nearest level 2 or 3 facility that is within your area. So, but for services that are beyond that, we have gazetted the prices and the benefits that you are entitled to. So when you go to that facility for services, is now when they will tell you you're entitled to this amount and we charge this amount.
What happens if someone falls sick and they're far from the facilities that they selected?
You go to the nearest facility.
Okay.
You haven't selected, but at that time, because you are out of your primary care network, so you just go to the nearest level 2 or 3 facility in where you have fallen sick.
Okay.
Yes.
So if I registered, said I'm in Nairobi, and I find myself in Lodwar, I'll still get services in
You will
Lodwar.
still get services in Lodwar.
Okay.
Yes.
And how will citizens file SHA complaints?
So the first complaint is you raise it with the management at the branch level or at the headquarters, depending on where you are. If you are not satisfied with the answers or the way it has been resolved, then you can escalate it to the tribunal that has been set up. So that's where now you escalate your dispute or your complaints. But to begin with, you raise it with the internal mechanism will be able to handle. If you're not satisfied, you can escalate.
Okay. How often can I update my details on the system? So, for instance, when I registered for the system, I said I earn 100,000 from my employer, and then things change. My income has gone down to 30,000, or maybe gone up to 500,000. How often can I update that in the system?
So if you are employed, it's not actually for you to update. It's your HR who will upload because this is a statutory deduction. So they are the ones who will upload your new salary and deduct the 2.75%. So as a formally employed salaried person, you don't need to update. It's your HR who will do. But as someone who is in the self-employed category, because you have paid your premium annually, so at the end of the year, you will be able to do again PMT to update what your new premiums will be.
Okay. And what happens if I lose my job?
You move into the non-salaried individuals. So you will move away from the category of salaried, you move to non-salaried. Non-salaried, now you will go through the PMT, and then you will be able to, it will give you your premiums based on the results of the PMT.
What is PMT?
Proximus testing. It's a way of calculating what is your premium based on the answers that you have given that you will answer.
Okay. And what happens to the unemployed who also have no business and they can't fit in the indigent group?
So that's someone who is not an indigent, has earnings, but they are not regular. So it means that person we will provide premium financing mechanism where they're able to borrow and then pay slowly based on the erratic income that they have at zero interest. So meaning you will be able to pay your premium for the whole year, then you pay slowly based on the earnings that you will be making over the year. So you don't have to worry about on how to finance your premium.
What happens when the main contributor dies and leaves behind dependents who are unemployed?
So if you are in the informal sector and you had paid a premium for the whole year, your dependents will benefit for the rest of the year. And of course, will undergo the PMT and will become indigents if the spouse that has remained is not able to make any form of earnings. And if you are formally employed, the same process. The dependents will undergo PMT, then either can be categorized as indigents, who will be paid for by government, or will be given premium financing to pay for premiums. But more importantly is to keep in mind that whoever has paid for the whole year will continue benefiting, even if
Main contributor.
the main contributor is no more.
Okay. Are there penalties for late payments?
Yes, it's at 2%. So if you look at for 300 shilling, it's 6 shilling.
Okay.
Previously, it was times 5. So if it was 300, it would have been times 5, 1,500, which was punitive. Then the amended one made it 10%. But for SHA, we just put a small percentage of 2%. Yes.
So this is 2% per month that you have not paid?
Yes, yes. Okay. So for every month, if you are paying 300, that's 6 shilling. Yes.
Okay.
For a year, it's 72 shilling.
Okay. And will I be refunded if I don't use my premiums?
That's not how insurance works, because there's a time you will also use more than what you have paid for. No one will come to ask you to top up your premium because what you have used is more than what you have paid. So the whole essence is this basket that we have all contributed to. No one wishes to be sick. So the fact that you did not fall sick does not mean you need to be paid back what you have contributed.
And will I be able to access facilities when I failed to pay my monthly contribution?
You are entitled to primary health care and emergency, whether you have paid fully or not paid partially. So yes, you will still get benefits but under the primary health care and emergency only. For social health insurance fund, you have to have contributed. Yes.
Okay. And why are some cover limits like dental solo, unlike in NHIF?
NHIF did not have dental unless you are a civil servant. And this is just based on the priority areas in terms of what the basket of funds that we have, what can it cover based on the disease burden and the need of the population, and what is it that will push people into poverty. That's why you will find things like dialysis, the cover is almost 1.2 million. Things like transplant will pay for 1.2 million. So you realize that that kind of benefit is the one that will make people call for Harambe, and that's the one that will make people sell their cars, their houses, withdraw all their savings, unlike unlike certain other things. And we have also set up the committee that will also start looking at what benefits need to be prioritized and what tariffs need to be paid. All that will be done scientifically, and Kenyans are allowed to petition and ask on what is their priority and what is it that they need to be covered going forward. And they will be able to participate in this new social health authority. This is the first time you are involved as a Kenyan in what needs to be covered and how much the authority should be paying. So we have a great opportunity to participate in even coming up with what do we need to focus as a country.
Will pending NHIF bills and settlements be taken over by SHA?
Yes, that's what the transition clauses say. Everything that is assets and liabilities have been inherited by the Social Health Authority.
So
There's
now,
no vacuum.
oh, okay.
Yes.
Okay. In almost all services in tariffs under the new system, they're extremely low. And some Kenyans are worried that they may have to pay cash to offset some of these additional expenses. So how is the new model helping people if they'll still have to pay some cash from their own pockets?
Number one, it's false. What seems to be low are the new benefits that have been introduced. If you compare what NHIF used to pay and what it pays now, what SHA pays, all the previous benefits, the SHA benefits have higher reimbursement. Take, for example, dialysis. It was 9,000. Now it's 10,000. Look at transplant. It was 500. Now you are talking about 700. Look at the benefits for post-transplant medication. It was not there. Now it's there. It's 200,000. So when you look at the specialized lab services, those things were never there, but they are now available. So comparison-wise, the benefits of Social Health Authority far outweigh what was there previously in NHIF in terms of scope and in terms of price. So the scope is what people are confusing. So you realize when you have a new scope, a new benefit that was not there is now what is being pinpointed as low. And the other thing that you need to realize is some of these benefits were only available to civil servants. So they were not there for the whole population. It was for the select few, mainly government employees.
So for example, like what are these additional benefits that are not there? Dental, you've mentioned.
Dental, renal, the post-transplant medication, specialized lab services. So all these things, emergency, so all this evacuation, These were only available to the civil servants. So now these are new benefits for everyone that has been introduced.
Okay. And how will this system help when it's operating under the same infrastructure where hospitals were understaffed, under-resourced, and had no drugs?
That's why we have given you the power to you, the individual, to make a choice on where you will get services. So no one is limiting you to go to under-resourced, underfunded, underdeveloped facility. As a Kenyan, you have the power to make a choice. The choice is with you. SHA only pays for services that were given. So you have the leeway to go where you will get your services. And that's where SHA now will pay. So money will follow services. So we are not paying to a facility and then telling you go there and get services. We are telling you go to where you think you will get services, then we will pay for it after you have gotten the services. Then Kenyans also need to realize that one of the 4 laws that was passed is the facility improvement financing, meaning that we have put a law to ring fence the money that comes to the healthcare space, especially health facilities. And those health facilities have community representation. So they should be able to hold accountable the leadership and the management and the board that are in charge of those facilities for poor service and for inadequate personnel. So I would urge Kenyans to be able to participate in their health by being part and parcel of those management boards of all public healthcare facilities as part of their duty.
What happens? Say you have your dental cover is 2,000 under SHA. What happens if you exhaust that cover?
So what we had, the design for the 3 funds, the reason why we had the emergency chronic critical illness fund was to address those kind of issues. If you have a critical illness or a chronic condition that you have, for example, you need dialysis 3 sessions or 4 sessions, the the emergency chronic critical illness fund was supposed to kick in so that you are able to continue benefiting rather than now going back to pocket paying for it. That is why we have this to be a tax-funded fund for people to continue getting services.
Okay.
And that's why I still don't understand why people are saying we just want to have NHIF because they haven't understood the design of this, which is meant to cater for not only from your contribution, but supplemented by tax from Treasury to continue getting services when your benefits have, when you have run out of your limits. Yes.
Why did Linda Mama and Edu Afia have to go?
They haven't gone. Linda Mama has been replaced by Linda Jamii. So meaning if you are benefiting from Linda Mama, now you have, because it was covering only delivery, now we have given you not only delivery, but also other benefits, including covering your whole family, including your spouse, including your other children, so that subsequent admissions or needs that you have, you will benefit. Postnatal, admission, any other issues that you need. That's why Linda Mama has been replaced by Linda Jamii. So it's not gone, it's just that it has been improved and the services and the scope and the people who need to be covered have been increased from one individual and one event to the whole family, and many other events that they might need. Similarly to Edu Afia was also covering just one student in a public secondary school only, despite, irrespective of what cover they have. So you would find this student has his father or his parents have another cover, whether it's NHIF, private insurance, or whatever it is. So they were covering only that. So what we are saying is, instead of just covering one student for just in public schools, we are covering all students in all schools, irrespective of public or private, and we are covering plus their family. And those are now the ones who need it, not someone who has one and you are duplicating, giving a secondary cover. So this new system is supposed to cover everyone, irrespective of whether they are in primary or secondary school, and that cover is extending to the whole family rather than just one individual.
How was Edu Afia and Linda Mama losing money?
So what was happening is facilities were charging Linda Mama and charging for the second cover you had. If you had a normal NHIF, so they will claim NHIF and they will claim Linda Mama
For the same service?
for the same services, because they know that both are going to be paid. The other thing is rogue facilities were just claiming Linda Mama even when they have not delivered anyone, because that did not need any biometric, did not need any registration, did not need. So all you just needed is to claim and say, I've delivered 20 mothers, 30 mothers, 40 mothers. And for all we know, they could have been even men that you have put in as from a phone just to register. And that was it. That's all you needed. So there was no way of verifying who exactly was benefiting. For Edu Afia, the same thing. If you look at the age group, it was Form 1 to Form 4 in public schools. Those are the healthiest population. But every year, when you look at the numbers, they have exhausted the cover. So you wonder, how can the healthiest population be able to benefit 100%, deplete its cover? Similar problem, there was no biometric, there was nothing. So you can have easy collision between the school headmasters and nearby facilities, or the school teachers, whoever was able to bring the students to those facilities. And the process of claiming started from there. No one has ever taken their biometric, so it was all systems go. That's how those two schemes used to lose money. The contribution has been made equitable based on your ability and your income. That's why it's proportionate, 2.75%, unlike previously, which was regressive. The poor were paying more percentage, up to 5%, even some up to 10%. If you look at someone who is in Mamamboga, who earns up to 5,000 but pays 500 shilling, was paying 10%. So that regressive nature has been removed. What we have done is we have a proportionate 2.75%, which makes us equitable going forward. And the same benefits equitably, so that we also get services, not on how much you have contributed, but on the need of the service for the individual. The cartels or facilities that have engaged in fraudulent activities, will be punished, will not be enlisted by SHA, and will not continue providing services under SHA if you find out that you have engaged in fraudulent activities. That will not move to the new system.
You find previously in a HIF, people were paying 500, 1,200, but now the contribution has increased. People are paying even more than 20,000, 15,000, more than what they are contributing in HIF. What has brought about this difference?
Not everyone's contribution has increased. What we have just done is we have equalized on how the contribution is made so that the poor don't pay more vis-a-vis those who earn more to pay less than what they are earning. So for example, people who earn 30,000 and below will actually have a drop. The mama mboga who used to pay 500 will also have a drop because the minimum has been reduced to 300 shilling. So it's not true that we are paying, there's an increment in contribution for everyone. So the increment in contribution is just has been necessitated by equalizing the contribution and making it proportionate. Because previously we were doing regressive scheme where you are punished for being poor and you are given an easy way out if you are rich. That's why you had a limit of 1,700 as a maximum. Now you can ask your benefit.
So there have also been some complaints online where people feel the benefits, it's not enough, it's not going to be enough. So for example, to have a baby, normal delivery, 10,000 shillings. The people who are saying that's not enough money to cater for that service.
So if you look at maternity delivery, even within the same hospital, you will find, depending on where you are, you will pay different prices. So you will have general ward, a certain amount, semi-private, a certain amount, private, a certain amount, executive, a certain amount. So you are all in the same hospital, but paying different. That is just pricing based on the extra hotel services that you get. It has nothing to do with what's the cost of that services. But more importantly, you need also to realize this is a social health insurance. So you are pooling the risks and the funds and then coming up with a benefit and giving them equitably. So you will get all these benefits in many hospitals without being co-charged. But what we cannot guarantee is the hotel services that you will need. That is a choice that you will be making. Compared to, if you compare it with the airline, some will fly the economy and another one will fly business, but you will all reach the destination that you are going for. And that's what we have at the Social Health Authority.
Perhaps just for clarification, what do you mean when you say hotel services?
I've given you the example of, in the same hospital. You will pay for normal delivery 40,000 if you sleep in the general ward and share the ward with many other people. If you go to semi-private, you have your room, but you will share the washroom facilities. If you are in but you will pay 100,000. But if you go to the private room, you will have your own washroom, but you will pay 150. But if you move to the executive, not only do you have your washroom, but you have even a sitting room and an extra bed for your spouse. Then you will pay 250,000. You see, all those things are choices. But at the end of the day, all of you have been looked after by the same nurses, given the same medication, and you will all walk out with your babies. but you have paid different prices based on what other extra that you need as an individual.
Okay. What is the difference between SHA and NHIF?
So the first difference is NHIF was a members club. You needed to have registered, paid for you to benefit. SHA has three funds. Two of them cater for, which are tax funded, that does not need you to have been paid up member. So all you need is to register for you to benefit from primary health care fund and for you to benefit from emergency. Secondly, the composition of the governance structure at the board level. Thirdly, is to look at how the benefits and the tariffs are designed. For Social Health Authority, that is completely out of its mandate, and that is in the public domain, where Kenyans can also ask to be included in terms of on what is the benefit that needs to be onboarded and what is the tariff that needs to be set up. Fourth, it is the way to the providers who are being empaneled. NHIF used to do it itself, and that meant that the process could take up to 1 to 2 years to onboard new providers. But currently, because the Social Health Authority has that mandate is not within its powers, it has moved to the Kenya Medical Practitioners and Dentists Council, and by law, once you are empaneled, SHA will empanel you within 30 days. So meaning you no longer, the Social Health Authority is not at leisure to do that process in a year or two. The fifth thing is the administrative cost. For Social Health Authority, it has been fixed in law, meaning that it can only use up to a maximum of 5%. NHIF did not have a limit, so it could go as high as possible. 20, 30, 40, 10, 15% of what it has collected. So if it has collected 100 shilling, it can use 50 shilling, 30 shilling, 40 shilling, 10 shilling. But for SHA, for every 100 shilling it collects, it can only use 5 shilling to manage. 95 shilling will be used to pay for services for Kenyans. NHIF also had the ability to invest. So they could use the money, buy properties, buy land, buy whatever that they wanted as a means of investment. SHA is not allowed to invest. So all it does is administer, use the funds for service payment. There's no luxury of investing or buying things that are not necessary, because it's not in the business of investing. The other thing that is different is the dispute resolution. NHIF currently is the one that resolves the disputes on its own with providers. With SHA, it has a tribunal that has been set outside by the Judiciary Service Commission to solve disputes that arise. So you will realize there are checks and balances on what SHA can do, while NHIF was the mother of everything. They could do whatever that they wanted, however they wanted. They were a law unto themselves. That's how the act was designed.